Hey there, and welcome back. Today we're going to talk about hormones. I feel like hormones are one of the biggest topics of debate in the medical community and probably the primary reason patients reach out to me when they're having hormonal symptoms but not really getting what they need from their traditional primary care doctor or even their OBGYNs. For many years, hormones have been withheld from women. A lot of the problem with women's hormone replacement therapy started with a study that was done in the early 2000s called the Women's Health Initiative. This was a study that was designed to see if hormone replacement could actually extend our lifespan by reducing cardiac disease, cancers, and neurodegenerative disorders. And the study was stopped about 4 years in because of a reported 400% increase in breast cancer in one of the arms of the study. So very important when you're looking at numbers in a study to actually understand what they mean. In that population of women, which was about 6,000 women, it was determined that naturally about 3 out of 1,000 would get breast cancer. And when they started the study, one of the arms, the one that had the estrogen plus progestin, saw an increase in breast cancer. And that number went from 3 out of 1,000 to 8 out of 1,000. And that was determined to be a 400% increase. But if you really look at the math here, that was not a statistically significant number. For instance, if I tell you I had $1 in the bank for retirement, and I increased my savings by 400%, that's still only $4. And so the absolute versus relative risk really got confused here. That's the press that went out, and every doctor took their patient off of hormone replacement. I was even practicing in those days in emergency medicine in the early 2000s, and I pulled my own mother off of her hormone replacement. So I'm just as guilty as the rest of the medical community for misconstruing that data. Since then, we've done a big look back at this, and we realized a couple of things. One, that the chemicals that were used in this study were pills that were given orally, very different from the topical bioidentical hormones that we use today. The estrogen that was used was horse estrogen, equine estrogen, and that's not our bioidentical estrogen. We are not horses. Our estrogen metabolizes into 3 different metabolites, whereas horse estrogen metabolizes into about 40. Some of them can be carcinogenic. Our bodies are not used to dealing with that kind of estrogen. It would make sense that our bodies would not receive or act as well on these drugs. The other thing to remember is that the progestin, which was in the study, was not progesterone. Our ovaries secrete a chemical called progesterone. Progestin that was used in the study was actually a chemical that's more similar to the male testosterone than it is to our bioidentical progesterone. And so when we look at the study, the women that did poorly were actually the ones that were in the horse estrogen plus fake progestin arm of the study. The other side of the study, which was just the horse estrogen, actually had a decrease in breast cancer. So you can see that sometimes studies get reported, but that information isn't really construed the right way. It can be very misleading. So we'll see a little bit later in the program. I've given a little more information about this, including the North American Menopause Society position statement, where they state that bioidentical hormone replacement is the best therapy that we have for preventing hot flashes and night sweats, those vasomotor symptoms we get from menopause, and also protecting ourselves from osteoporosis as we age. I've also given another resource here for women that are perimenopausal or menopausal. This is a great read, Estrogen Matters. It's available on audio tape as well as in a book, and it gives a lot of information about the studies that have been done, what they actually mean, and how to translate that information into English, because some of these can be quite hard to understand. When we look at men's health, we usually are talking about testosterone, even though both men and women have testosterone, and women actually have more testosterone than they have estrogen. Men's health. Testosterone has been decreasing over the decades. If you were to check your testosterone levels and you were in your 50s in the 1990s, then you would expect to have a level around 750. That would be considered normal and average. Today, that same man is expected to be around 550. I see many men below 50 years old that are in the 300s, which is diagnostic for low testosterone. There are a lot of reasons for that. There are a lot of estrogen-like chemicals in our food packaging, including our bottled water, in our shampoos, and this, I believe, is causing a feminization of our men and early puberty for women, and that could account for the low levels of testosterone we're seeing because we're losing it to estrogen. When we evaluate hormone levels, it's not just important to know from a blood test what your actual level is. For instance, the sex hormones testosterone and estrogen travel largely bound to proteins called sex-binding globulin and albumin. And once these hormones are bound to these proteins, they are sucked up. They're not free to do their job. You can only really use as much hormone that is free. And so think of your body as a car factory, and you might have 1,000,000 tires, but you only have 5 frames. Well, you can only build 5 cars. And so it doesn't really matter what your total testosterone level is, or sometimes even what your total estrogen level is. You need to know how much of it is available in circulation so that you can use it. Another thing that can interfere with hormones without affecting the total number of your hormone on your lab test would be inflammation. Inflammation can block the binding site of the hormones. You get the inflammatory cytokines binding there rather than the hormone, and then the hormones can't get in. Imagine that same car factory is on fire. Nobody can get in to get to work to build your cars for you. If you have a poor nutrient supply, let's say you're not getting in enough protein, or you're on a super low carb diet, or you're not taking in enough vitamins or minerals, or maybe you have extremely low cholesterol, which is very rare but can happen, then you're not going to be able to build these hormones correctly or utilize them. A lot of these vitamins and minerals are cofactors in these chemical reactions. Evaluating hormones also requires more than just drawing a blood and looking at the number on the paper. You want to know all of the past medical history. What symptoms are you having? What is your family history? Have you had traumatic brain injury as a younger adult? That could be disrupting the signal that gets sent from your brain to the end organ to make the hormones. We also want to do an expanded lab panel. As I mentioned above, we need the raw hormone levels, the usable free numbers. We also need to look at the precursors of those hormones, the signals that come from the brain, the inflammatory markers, nutrient levels. How well is your liver working at providing the chemical reactions that sometimes need to occur in order for the hormones to be removed from circulation? Timing and method of testing is super important, particularly in women. In a woman that is cycling, if you check the blood during different times in the cycle, you're going to see different peaks. For instance, your estrogen will peak towards the beginning of your cycle, right after you've started your period, whereas your progesterone will be negative. You're going to see your progesterone spike shortly after you ovulate, after the middle of your cycle. So timing is very important. Cortisol is another one. I see people check for cortisol in the blood. That's not very accurate. I have a tourniquet on your arm. I'm poking a needle in you. That cortisol level is probably going to spike for that blood draw. A better test is to have a 4-point collection over the course of one day to map out that level, and it's best checked in the saliva. Growth hormone is active at 4 a.m. and only lasts in the body for less than an hour. It's going to be gone if I draw your blood at 8 a.m. Better to check an IGF-1 or even an IGF-1 BP3, depending on what time of day we're doing your blood draw. As I mentioned above, both men and women need testosterone. Women actually have more testosterone than they have estrogen. It will naturally decline in the same way your progesterone does as you age. And testosterone is great for improving blood flow to the heart, to the brain, to the genitals. Helps a lot with libido. So having levels that are optimal in both men and women is good. Treating low testosterone. If I put you on testosterone, guys, I'm going to take over. Your brain signal is going to say, oh, we've got plenty, we don't need to make any more. And so there are about 25% of people, when they stop testosterone therapy, will be unable to start making their own. In other people, it can take about 6 months to even a year to get your body to start kicking up production again. So we don't take the decision lightly. We do it after we've exhausted other possibilities, like nutrient supplementation, or even providing the brain signal to the testes if that's working slowly. Sometimes we can get the testosterone to boost in a more natural way without taking over the whole thing. If I do put you on testosterone, you will most likely become sterile as a male. Your testes will shrink. You will no longer have the signal from the brain telling your testes to make sperm. And so your testes will get small because of that, and you will most likely be infertile. There are metabolites of testosterone. When it breaks down in your body, it will turn into a hormone called DHT, dihydrotestosterone. That's actually the usable testosterone in the brain. It's what is responsible for libido and your general sense of well-being. But those receptors are also very active on your skin, on your hair, and in your prostate. And so men that tend to, or women that tend to hypermetabolize into DHT can get acne, hair growth or loss, or prostate growth. Estrogen is also a metabolite of testosterone, and I especially see in people who have a lot of adipose or fatty tissue. That's where there are receptors that help convert testosterone to estrogen. I see these men or women tend to have higher levels of estrogen when they get supplemented with testosterone, and that's something that we can block if we need to. But we also need to know that the body is going to excrete that estrogen rather than letting it continuously circulate like bad karma in your bloodstream. That's where a Dutch estrogen metabolism test comes into play. This is done on both men and women. If you have an increased risk of blood clots in yourself or in your family for some reason, usually it's a genetic defect, that can cause you to become more clotty with estrogen or testosterone replacement. You can form blood clots, and blood clots can be life-threatening. This is something that we screen for in a family history, but there are also genetic tests that can be done. Topical testosterone replacement can be tricky because topical testosterone, when you rub in the cream, it will absorb onto your fingertips, and that can then transfer to your housemates or pets, and it can even transfer to laundry or toilet seats. So you want to make sure that in giving yourself your topical testosterone that you're also not giving it to your family members. There are a couple of links here you'll see. This is a link to my Hulk protocol in Fullscript, which is a list of supplements that can naturally boost your testosterone and can be used for both men and women. When it comes to estrogen and progesterone, we don't typically replenish estrogen in men. They will lose enough of their testosterone into estrogen usually. Progesterone sometimes is supplemented in men, especially if there's a lot of anxiety or stress going on. Progesterone has a metabolite called allopregnanolone, which is very calming for the brain. Here again is that North American Menopause Position Statement. This society is considered the gold standard for information about menopause, and they state in their most recent position statement that hormone replacement therapy is best started within 10 years of going through menopause in order to achieve the beneficial effects that it promotes. So the vasomotor symptoms and the bone protection, these things are all more beneficial. If you wait until you're 70 to go on estrogen for the first time, you have a more dangerous safety profile. It's never letting ourselves go through that dip in estrogen that seems to be the most protective from a long-term standpoint. I briefly went through some of the confusion on hormone replacement therapy for women, but this gives you a little bit more information about some of the misnomers about women's hormones. This is a link to the book Estrogen Matters. I love this book. It's a great resource. I think any woman or somebody who's supporting a woman going through menopause or considering hormone replacement, this is a must read. It's not super scientific. It's very easy to digest. It goes through the literature, how things became confused and misrepresented, and what the real facts are when it comes to hormone replacement. Growth hormone is another hormone that I discussed earlier, essential for growth of your tissues. It doesn't cause cancer, but it certainly can promote a cancerous cell that's already there to grow a lot faster. So in people that are interested in replacing growth hormone, First, we like to clean up all the underlying hormone abnormalities. It's the last one I like to address. And we do aggressive screening for cancer, and we make sure that we are very much on top of our annual recommended screenings if we start growth hormone. Thyroid, in my opinion, is an incredibly under-screened for hormone abnormality. Most internal medicine doctors' recipe is to screen for TSH, which stands for thyroid stimulating hormone. This actually isn't even a thyroid hormone. It's a hormone that comes from the brain that tells your thyroid gland to kick out the thyroid hormone. And so if you are only looking at the thyroid stimulating hormone, you might be missing something that's occurring further down in the cascade. Also, it's important to remember that the labs still have the upper limit of normal on that TSH study as 4.5, when it's been determined for over a decade by the Endocrine Society that it should not be higher than 2.5. And so there are a lot of people that are falling between the 2.5 and the 4.5 that aren't being screened any further simply because the lab has the wrong top end of the range as their threshold. Hashimoto's is a very commonly missed thyroid disorder that's caused by an autoimmune attack on your thyroid. Your body is being stimulated by something. Usually it's something you're eating. Many times it's wheat. And that inflammatory process is interfering with the thyroid function. You're going to miss this if you're only checking a TSH. Vitamin D3 is a hormone, and if you remember back even 5 years ago, most internal medicine doctors were not screening for this. Think of all the other things that we're not looking for that maybe in 20 years will become normal run-of-the-mill tests that are being ordered. Well, that's what we're doing in Club Optimize. In Club Optimize, we are not waiting for science to catch up with us. We are looking at these things early. We're looking at the latest literature and the confusion in the literature and applying these principles to safely help optimize hormones for people that are suffering with symptoms. You'll learn more about your individual hormone issues within Club Optimize. We'll dig into your personal history, your previous labs. We'll order some more additional diagnostics if necessary and see what we can do to make you feel better in a safe way, and then guide that process with frequent reevaluations, screening to make sure that you are detoxifying appropriately, getting good screening studies when needed, keeping up with your pap smears, mammograms, testicle exams, digital rectal exams, colonoscopies, etc. You'll get all of that information and guidance within Club Optimize. This was a very long module just because there are so many hormones, but they will become easier to understand as you go down your own journey in exploring these with me in Club Optimize. If you would like to join, you will be given an opportunity at the end of this program. I think we only have 2 more modules left, and then you will be given an opportunity to sign up. But please feel free to reach out with any messages through the BodySite messaging app. You can contact me and I will respond. Have a wonderful rest of your day. I look forward to hearing from you.